Hi, my name is Brian Golden. I'm the Sandra Rotman Chair in Health Sector Strategy and a Professor of Strategic Management at the Rotman School. I'm an expert on health systems, health system design, payment models, also a Professor of Strategic Management and an organizational psychologist and economist by training. And I'm here to answer your questions about health systems, and who doesn't have questions about health systems and healthcare. Welcome to my office hours. What is the biggest choke point or bottleneck in our current healthcare system, and how can we fix it so that clinics and hospitals can see patients faster? Now, it's a tricky question because first, we don't have a single healthcare system. So across Canada, we have provincial and territorial systems. We have challenges in every one of them, and they're slightly different. The other challenge is that there isn't a single choke point or bottleneck. I would say there are a few areas that we need to work on. First is we haven't invested sufficiently in hospital beds. We have fewer beds in Canada than other rich countries. Another problem is that we have a dearth of health human resources. We are seeing increasing retirement or burnout of our physicians, our nurses, other allied health professionals, and that's a problem, obviously. The other challenge, and maybe this is the most fundamental challenge, is an insufficient or weakened primary care system. 6.5 million Canadians lack a primary care physician. They simply don't have one. And then for those of us who do, we're lucky, but we may have difficulty seeing a primary care physician hours tomorrow, today, 3 days from now. It may take some time. So we focus a lot on healthcare as opposed to health. If we can keep our individuals, our citizens healthier, we wouldn't need so many hospital beds, but we do today. A big question, particularly given where we are post-COVID, or hopefully post-COVID, is considering the time savings. Goodbye waiting rooms, hello comfy couch. Why isn't our healthcare system going all in on telemedicine? My view is we shouldn't go all in. It is very appropriate under certain circumstances and given the geography and the vastness of Canada. So given that many people don't live 2 blocks away from a physician, we can really benefit from a quick visit, a quick conversation, whether it's a telephone call or a Zoom call, the equivalent. I'm not a physician. I'm not a real doctor, as my mother says. My physician friends tell me there are just some things they'll never be able to diagnose in a Zoom call or a telephone call. This is not defensiveness on their part. Many of them prefer telemedicine. There is a view that a doc can be a doc on a doc, and they love that. It's good for their work-life balance also. There's another fundamental challenge. During COVID, we got very good at this. It was really our only alternative in many cases. But the challenge was then we were paying sufficiently for that. What our provincial and territorial health systems have done in many cases is they've clawed back the funding for the telemedicine visit for physicians. So now what physicians are saying is, I'm going to get paid less to do the same work, to deliver the same quality. I'm not good with that. So I want patients to come in. So we have to find an equilibrium where it is good for healthcare providers to provide telemedicine, where they have the technology, where they can provide a quality visit, where patients prefer it. We're not there yet, but we've made incredible advances having learned from the COVID experience. Is there a trick to getting seen by an ER doc faster? Should I slip the intake nurse a $20 bill? There are a few tricks. First, cut your finger off. If you're bleeding out, you're going to get in faster. If you have 105 fever, you're going to get in faster. What we do in the ER appropriately is we triage. So if you've got a queasy stomach and you really have a medical condition that isn't urgent, you probably shouldn't be in the ER, but you're there because you've got no other alternative. You're probably going to wait. You probably don't want to go on a Friday night in a large urban area where there's just been too much time at bars and people aren't feeling well, or they've gone into fights, or even worse. So there is no trick to getting seen faster in an ER other than going to a less busy ER. Better trick is staying healthy, trying as best you can to see a primary care doc, to be connected to one. Take care of yourself. Slipping a nurse $20 won't do it. Slipping a nurse $100 won't do it. You really need to be very ill to be moved quickly through the emerge. So is it me, or are Canadians obsessed with comparing our health system to Americans? we are obsessed with comparing our health system to Americans. I think the answer is because it's really the only way we can feel good about our Canadian healthcare system. We compare ourselves to the Americans because we consider ourselves providing equal care to all Canadians. That's not true. It depends on where you live in Canada. If you're in an urban area, you'll have better care or better access, typically. If you speak English as a first language, you'll have better access to care. Who you know, dirty secret, will sometimes impact your ability to get care. Your education level impacts your ability to get care. All of these things really do separate some Canadians from others. We rank just about near the bottom among rich countries, OECD countries, year after year, poll after poll. But we're just about the bottom, often just above the US. But we don't rank nearly as well as European health systems, Asian health systems, on costs, on access, and we're not improving. We haven't improved in well over a decade. Now a serious question. Sort of, why don't the ERs have a pinball machine or anything to make a wait room more pleasant? Why not a phone charger? Why not anything to make it a better experience? If you've ever spent any time in an emerge, you realize some people are very, very ill. These are chaotic places often. They're noisy places. People are stressed. They're with family members. We probably don't want to introduce a pinball machine or a disco ball, dance floor to make it that much more enjoyable. We don't want people showing up for a good time. But can we do things to make it a more pleasant experience? Sure. Can we have iPads? Can we have news on the screen? Most people find that they're bringing a phone, they're bringing some kind of device. So of course we should have phone chargers. That's an easy thing to do. But these are not places where you want to spend a lot of time. So rather than investing on making the ER a more pleasant experience, why don't we try to invest on not needing the ER nearly as much? How is it that you can go to a bank or an airport and all my information is at the tip of their fingertips, but hospitals rely on faxes to transfer health information? Why is healthcare such a Luddite? Part of it is we haven't kept up in investments. Part of it is some concerns around privacy, but I think we should set that aside. We know how to deal with the privacy issues. Part of it is just tradition. It is hard to manage change and to change workflows in a professionalized healthcare system. But we have no good excuse. The only places that use faxes today are hospitals. And we have a campaign across the country to axe the fax. This is changing, but it's too slow. Part of the challenge is new technology is expensive. We are investing billions of dollars, but we rely too often on the hospitals or the clinics to do that as opposed to our central ministries of health. And that's silly. We should be doing it centrally where we can get to real scale economies in the technology and where fundamentally the ministries of health are on the hook for delivering care. They should be buying centrally, they should be sourcing, they should be implementing centrally, and then we have interoperability. Our systems are connected. Are there any alternatives to the fee-for-service model in healthcare? Yes. Doesn't that incentivize physicians and hospitals to take care of sick people rather than preventing us from getting sick in the first place? This is my biggest focus in all the research I do. How do we fund and pay and incentivize? So fee-for-service is basically you get paid as a physician every time you do something. Every time you lay hands on a patient, you get paid. Cha-ching, cha-ching, cha-ching. And this is a dirty little secret I say to my MBA students who are not familiar with the health system. Physicians are just like other people. They respond to incentives. And we want them to respond to incentives. That means we need to have intelligent incentives designed into the system. Fee-for-service often incentivizes physicians to provide more care. We see this especially in the US, but we do see it in Canada as well. And the US and Canada are outliers. We have between 75 and 80% of our physician compensation as fee-for-service in Canada and the US, and we've been slow to move off that. Kaiser Permanente is a health system we visit as part of one of my programs. It is the leading health maintenance organization in the US, very innovative. all of their physicians are on salary. They prefer it because they have a predictable schedule. They know what they're going to earn in the year. They monitor their physicians. So if their physicians are, quote, lazy, they're not. But if some aren't working at the same rate as others, they deal with them the way most organizations would deal with employees. They have a conversation about workload, about productivity, about quality. We don't want to incentivize physicians to have a 6-minute interaction with a patient if 12 minutes or 24 minutes is required. There's been a lot of talk recently about outsourcing of some surgeries to private clinics. And people wonder, is it really private healthcare if the government of Ontario or any other province is paying for it? This is a really important question. The question shouldn't be whether private providers are providing healthcare, but who is paying for it. As long as you come in with your health card and you have the same access to care as someone with more money in their pocket, then it really doesn't matter. We do get a little bit concerned about whether private for-profit corporations, the larger ones with shareholders, are going to provide the same quality of care as our nonprofit, publicly run hospitals. And that's a legitimate question. But we can put controls into the system. We should be monitoring, not only monitoring private providers, private clinics, private surgery centers, but we should be monitoring, and we do, hospitals, physician clinics. We should have quality assurance in every part of the delivery system of care. But we should not get fuss about whether a clinic, a surgery center is privately owned, as long as the government, our publicly funded health system, is paying for it and providing equal access to citizens regardless of how much money they have in their pocket. What exactly does a hospital administrator do? Are they doctors? Are they nurses? Do they have to get special training to manage a hospital? Does the province tell them how to run a hospital, or are they making it up as they go? I have so many questions. Provinces and governments don't tell the hospital management how to run their operations. What they do is say, these are the goals you need to achieve, whether it's X number of procedures, whether it's to improve the quality, whether it's to manage fiscally more responsibly. Administrators do not have to be clinicians. Increasingly, we're seeing more clinicians getting involved in the leadership, the administration, the management, and that could be doctors, it can be nurses. But the vast majority of administrators or managers are not clinicians. They are managers, they are trained, many of them are MBAs, many of them are Rotman MBAs, we're happy to say. These are big corporations. Some of our hospitals 5 minutes away from the Rotman School are $1 billion or $2 billion or $2.5 billion corporations. They engage in mergers. They engage in financing. They are innovators. They are entrepreneurs. They commercialize. They manage flow. They manage quality. So no one learns this stuff on the street. We do have to have specialized training. Hospital administrators are running incredibly complex organizations. They are fascinating places to work. That's all the questions we have for today. Visit the Rotman Insights Hub to learn more about healthcare management and administration. Thanks for joining me.